therefore, 7 times out of 10, if I have to image them, I would be doing an ivus.
Thank you.
Andrea, there was another question that you'd asked, but I would also tell you that much of the anatomical, you see, there are anatomical predictors of a high-risk patient, and that goes very importantly both for right coronary artery, which has an interarterial course when it arises from the left sinus, and those are very important, and that is also judged, by the way, on the CT. So CT coronary angiogram will predict for you also the way it arises at an acute angle. It also shows you the osteas at an angulation. It predicts the intramural course, which is the first few centimeters, well, first couple of centimeters or a centimeter of the anomalous RCA where it runs in the wall of the aorta. And therefore, those are the predictors of high risk. And that is why, that's the other reason why CT. So it's not just for its course, which is one of the very important aspects, but also for the high risk predictors, the anatomical high risk predictors.
Thank you so much for a great talk. It was very, very educational for me. I learned a lot. One of the questions that came to my mind was when you were planning for stage PCI for these patients, like, someone has anomalous coronary and one of the tough ones, and you're planning for a stage PCI, is there any benefit from radial versus femoral approach in your experience?
So that's a very, very good question. I am a femoralist more than radialist, okay? Though I do radials, I do less interventions radially than femorally. But you're right, femoral, but for anomalous coronary arteries, depending upon the variations and depending upon the changing of guides and the number of guide catheters one may need to use, modify, adjust, the same goes for diagnostic. Femorals are preferred, though, by the way, there are some publications related to using radials and how anomalous right coronary artery, which arose close to the left mean, can be done more easily through radial than with femoral. Okay. Now, whether that is really true, because that's a couple of publications related to that, I can't comment to that because I would never chase an anomalous right through a radial. I would always do it femorally, as you watch me do. But that's the only anomaly which is said to actually be easier through the radial in every publication, but majority of the cases, by the way, majority of the publications, case reports, etc., have all relied on femorals rather than radials. So you're talking about 90%, 95% of the publications actually being femoral approach to.
So my question is similar to Andrea's question about the physiologic assessment of these lesions. So if you have like an equivocal like CT or CT FFR, and then you want to do invasive assessment, I think that one of the problems with these lesions is that they are dynamic. They're not like the fixed calcified lesion. So how would you normalize for that? I think the FFR is probably not going to be, or the RFR probably may not even be positive, but it may be significant.
So should I say that I don't think anybody knows the answer to that question, because there has been very little related to measuring these indices in anomalous arteries without any lesions, which actually have no atherosclerotic disease. I have at least not found publications directly related to that. Angelini is the one who's done a lot of work around imaging these arteries. And I'm not, I know that there's publications on flow measurements, but I can't recollect what the assumption was. And certainly it doesn't figure out in any of the recommendations for evaluation of ischemia.
Thank you.
But there's a lot of, the physiology has been measured down these arteries by Angelini and great intravascular ultrasound images, as well as physiological measurements have happened very recently. But and he's done the most work on this.
Thank you.
So last question.
So do look up Angelini's publications on this.
As expected, there was a phenomenal session and we all learned so much, as always. I can't thank you enough. Have a great day. I look forward to seeing you in person soon. And we're going to ask you to do more lectures with us because you always give such practical advice from all your years of experience that the fellows love hearing. I learned from you as well too. Thank you, Ashok.
Thank you. And I love the fellows. I mean, they're all thinking so much. They ask me questions where I wish I was with them in the lab, sussing all these things out.